name is Dishita Agarwal, and I'm presenting on Unveiling the Invisible, tackling pediatric heart disease. A little bit about me first. I'm from Greensboro, North Carolina, and I'm a rising senior. This year, I placed internationally at Host of Future Health Professionals. I'm also the president of my school's Model UN team. I do Science Olympiad and Interact Club. I'm a youth health advisor for the North Carolina Department of Health and Human Services. This year, I did a summer internship with Duke Children's Hospital as well as Boston Children's Hospital. We created a curriculum on cultural humility to implement in medical practice. I have long QT syndrome. It's a congenital heart disorder. I was diagnosed when I was 2 years old, and it's what inspires me to do this project today. In the future, I'd like to study global health, epidemiology, and maybe even get involved in policy. Pediatric heart disease is an emerging crisis. 1 in 120 children are born with a congenital heart defect each year. Only 25% live in an area with reliable access to healthcare. For 90%, treatment is unavailable, unaffordable, or of suboptimal quality. Due to high expenses, pediatric cardiac care is often considered a luxury treatment when it's actually very integral to reducing childhood mortality. Overall child death rates since the turn of the millennium have decreased by half, and they're predicted to decrease by half again in 2040. But the mortality rate of pediatric heart disease remains overall constant. By 2030, congenital abnormalities will be the fifth leading cause of neonatal death. Congenital heart disease has the heaviest burden on countries with a high number of annual births and the greatest levels of poverty. 70% of the burden falls on low and middle income countries. For example, in Brazil, there's 9.7 cases per million GDP. In Kenya, however, there's 297.5 cases per million GDP. That's vastly greater than the United States, where there's 2.2 cases per million GDP. Even though the United States has a high number of cases, it also has a very high GDP. Access to care and family income are greater indicators of treatment and survival rates of CHD, much more than the actual severity of the condition. Congenital heart disease is not preventable or curable, but acquired heart disease is, and rheumatic heart disease is an example of that. 60% of RHD cases are caused by untreated acute rheumatic fever caused by strep infection A. Penicillin and antibiotic applications could reduce 70 to 80% of those cases. But because of lack of access, 300,000 school-aged children acquire RHD per year. It's responsible for 1/3 to 1/2 of all cardiac hospital admissions. Many congenital heart lesions can be treated with relatively simple interventions, but financial cost makes them often unaffordable. CHD is often misdiagnosed as common infections such as pneumonia, which then leads to untreated heart diseases and restricts access to life-saving treatment. CHD is often invisible when another illness arises, so it can even make the illness worse without knowing. By 2030, over 40 LMICs are projected to have the capacity to incorporate pediatric cardiac care into their health systems. And if that does happen, then 85% of children can survive until adulthood. For that, we need a multidisciplinary integrated approach, which includes access to quality care, well-trained professionals, team-based practices, safe equipment, and the ability to monitor clinical outcomes and infection control. It is feasible, though. Surgical costs range from 2.5K to 5K USD. That's around the same cost range of the treatment for children with HIV+, which is more of a national focus. Congenital heart anomalies are the greatest burdens of disease that could be averted with scaled up care and a greater workforce. One aspect we should focus on is preventative care, including universal screening, surveillance. Providers must recognize symptoms such as cyanosis, poor growth, or shortness of breath. They also should be able to use a stethoscope to hear murmurs and refer patients to cardiologists. Another aspect is surgical care. Only 7% of developing country populations have access to CHD surgery, but an optimal surgical workforce requires 2.3 million additional specialists for pediatric care needs. In North America, there's one surgeon per 3 million people. In sub-Saharan Africa, however, there's only one pediatric cardiac surgeon per 38 million people. Only 1/5 of pediatric cardiac surgeons attend to the poorest half of the world. We also need to collect comprehensive and accurate data. Global health communities must invest into clinical monitoring efforts to quantify and accurately reflect pediatric heart disease and country level burdens of disease, not just global. We'll need data on incidence and prevalence, treatment access and cost, associated morbidity and mortality rates, and economic impact. These efforts will require multilateral financing agencies, government, research institutions, civil society, and the private sector. Together, we need to promote local buy in and ownership to increase the capacity at lower domestic cost. When international medical teams come in and out of countries, they often lose trust with the community. That's why we need to encourage providers to stay in country and establish regional health centers of excellence. We also need to include pediatric heart disease in global and national indicators and establish telemedicine consultations in low resource settings. In conclusion, government donors and health professionals must prioritize investment in a robust, responsive healthcare system that can service the needs of families and pediatric patients with congenital heart disease. CHD will be a top 5 cause of childhood mortality by 2030. Advanced pediatric cardiac care must be considered universal and integral to reducing childhood mortality rather than a luxury treatment. These are the references I used to do my study. Thank you so much for listening, and thank you to my mentors at NCDHHS and Duke Children's Hospital for involving me in pediatric work and care. If you'd like to contact me or if you have any questions, here is my email and my LinkedIn. Please reach out. Thank you so much again for listening. Have a good day.